Hello and welcome back to GP Video Podcast by Nadia. So, as I made a short video podcast yesterday about menopause, and I think menopause is one of the most important topics that we deal with in GP world. In women more than 40 years of age. So, I would be making such more and more video podcasts which are short but contain some information about menopause. So we are continuing with that. Today I am at a website called Australian Menopause Society, and the topic that I'm going to, the subtopic that I'm going to discuss today is called estrogen only menopausal hormone therapy. And what does it mean? So it says that women generally undergo menopause between the ages of 45 and 55 years. So anything between the ages of 45 and 55 is definitely perimenopause. Around the time of menopause, many women experience symptoms such as hot flushes, sweats, vaginal dryness, loss of libido, irritability, sleep disturbance, and muscular joints and pains. Estrogen therapy is the most effective means of treating these symptoms. It will also prevent bone loss. So basically, we know that there are two female hormones that we talk about, which become up and down in a menopause period. They are estrogen and progesterone. So the one that does actually all the job is estrogen. So estrogen is the one that is needed for bone prevention or bone protection. Estrogen is the one that is needed for heart or for good cardiac functioning. Estrogen is the one that is needed for everything, for managing all the symptoms. Then why do we need progesterone? Why do we give progesterone to the women as part of HRT? Basically, what is progesterone needed is for, there is a lining of the uterus. And what estrogen does on that lining is it actually makes it really prolific. It makes it to multiply. It makes it to, grow. Progesterone antagonizes that effect of estrogen, and that is needed. Otherwise, that growth can lead to endometrial or uterine cancer. So progesterone is basically only needed for protecting the uterine lining. That's all. That's why we give estrogen along with progesterone to the women who are menopausal or perimenopausal and have got a uterus. Okay, so progesterone, you can consider progesterone as the protector of the uterus. Okay. Now, the women who have had hysterectomy, the women who have had the uterus out, they do not need progesterone as part of the HRT. This is very, 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 very important to consider, that women who have had a hysterectomy or who have had uterus out do not need progesterone as part of HRT. What they only need is estrogen, because progesterone was only prescribed to them for protecting the lining of the uterus. That's all. Now that the uterus is gone, we do not need progesterone. We only need estrogen. Now, who are the only women who would need progesterone with estrogen despite having uterus out? These are the people who have had endometriosis. So the women who have had endometriosis, what is endometriosis? Endometriosis is the presence of endometrial lining of uterus outside the uterus. So the women who have suffered endometriosis in the past, although they have had the uterus out, they might still need progesterone because they might still have the endometrial lining somewhere else that can grow as part of the unopposed estrogen administration. So basically it says that estrogen only therapy should be prescribed to women who have had a hysterectomy. There is no therapeutic advantage in prescribing progestogen, either a progestin or natural progestogen or natural progesterone, for women who have had a hysterectomy, with the possible exception of women with residual intraperitoneal endometriosis. So there is a debate here. Are we going to give progesterone to all those women who have had endometriosis in the past and have had all kind of endometriosis removed, or to the women who still have a bit of intraperitoneal, which is within the abdomen and pelvic area, they have got a bit of endometriosis left? So The only women who will get some progesterone are the women who have had a hysterectomy but have got the possibility or chances of endometriosis, or have had endometriosis in the past. Otherwise, ladies who do not have issues with endometriosis and have had a hysterectomy done, they will only get estrogen. If we give women, the women who have had hysterectomy, if we give them both progesterone and estrogen, there is a distinct disadvantage in terms of increased breast cancer and thromboembolic risk and adverse changes in cardiovascular risk factors. So instead of improving the chances of good cardiovascular profile, giving progesterone can actually have adverse changes and also increased risk of breast cancer and thrombotic risk. So estrogen only for women who have had hysterectomy done. All right, and we'll come back to this topic again in our next video podcast.